That's fine on both sides.
You're the host.
You able to see the first slide?
Yeah.
Okay. Thank you, Dr. Reddy, for the kind introduction. It's a privilege to be speaking at the Kalkala Subarao webinar series, and then it's a privilege. So good evening, everyone. Thank you for tuning in this evening. It's a Saturday. You have much better things to do, but those of you who have tuned in, thank you very much. When Dr. Reddy asked me to think of a topic, I think this was a topic I presented at the Kerala IRIA, I think probably 13 years ago. And it was still at its infancy in India at the time. I think it was being done at the metro centers, but not as prevalent as it is today, because now I've realized over the last 10 years, I've listened to a lot of talks and webinars from India as well on defecography, and it made me realize that it's actually taken off. But still, I think there's a long way to go. And I was just speaking to the panel before the presentation, and I think we still need more centers doing this. And I think, so what I actually did was I took out the presentation from 10 years ago, and I said, oh, I can just show this again. And I just realized that so much has changed since 10 years, and a lot of classifications, a lot of pathology that is becoming more prevalent has changed since then. And actually, it was a great learning exercise for me as well while I was putting together the presentation. So I think the basics are the same. Our understanding of anatomy and physiology is key in doing defecography, but I think a lot of other things has changed over the last 10 years. So I think we'll just go through that over the next 40 minutes or so. So I'm Dr. Jagdish. I'm a body radiologist at Sheikh Shakbout Medical City in Abu Dhabi. And I started the service when I moved to SSMC, I think 3 years ago. And every time you move a hospital, it's back to square one, because you need to convince clinicians, you need to convince your patients that there is a test that can tell you why you're having pelvic floor symptoms. And initially, it was a trickle. I had, one a month. I would have sometimes 2 in 3 months. But now we've reached a stage where we are doing probably 4 or 5 a week, sometimes 3 a day. And we've, crossed, the 600 mark in a very, very short period of time, in a couple of years. So I think the patients are becoming more aware. The physicians are finding that the impact of imaging information is changing what they do. Unnecessary surgeries are avoided. And we'll go through all of that during the presentation. So the overview of the presentation is to look at why we need MR imaging and when we need MR imaging. But the major chunk of the presentation will be how to do it, especially for radiologists or radiographers tuning in today who would like to start a pelvic floor service. This is an overview of how to do it. And for people who are already doing it, I would love to hear how you do things differently compared to what I do at my center. So we look at some anatomy. The pelvic floor anatomy, unfortunately, is complex compared to the rest of the body. But once you, once you dissect through it, imaging-wise, I think it's quite easy to follow. We'll go through techniques, the protocols we follow, and the tips to get a successful exam. That's key in this exam, to get a successful exam. We'll do some measurements, the basic measurements and the angles. And we'll go through interpretation and examples. And finally, we'll go through some cases. Okay. So why do we need MRI? Why do we need imaging at all? I mean, we have fluoroscopic defecography or proctography. We have the ultrasound, translabial ultrasound pelvic floor evaluation. We're not going to talk about that today. But why do we need imaging? I think the point is that there is a high prevalence. And we're only imaging a tip of the iceberg, or only tip of the iceberg is being diagnosed. People don't want to come forward with their problems. They find it as a social taboo, but the prevalence is very high. And it's predominantly in the elderly female population. 50% of them have some degree of pelvic floor weakness, though only 10 to 20% are symptomatic. But, and the main complaints are, tissue coming through the pelvic floor, urinary incontinence, and obstructive defecation. Now, age is a factor. As I said, elderly population are more at risk. And once you're above 80, the prevalence doubles. But what I find recently, of late, is that we have much younger population coming through. Now, again, I was talking earlier, a big chunk of my population is between 20 years and 40 years. And these are not even multiparous women, and some of them are even men. And we have like 20% of my patients are men. And these patients are quite young, and they are coming predominantly with chronic constipation. So, and we'll go through why that is becoming more common these days. Parity obviously is a risk factor. If you have more than 3 children, your ligaments, your pelvic floor muscles are stretched. Some of them are disrupted during delivery, depending on the type of delivery. And overweight patients, again, going back to the young population, overweight, sedentary patients tend to have low pelvic floor tone and poor contraction. And what does this do to the patient? I think it decreases the quality of life. We look at it only from a structural perspective, but once I start talking to my patients, you realize how much it has affected them personally, in their personal lives, in their social lives. They become introverted, they don't go out because of the difficulty. It really affects their life, and the quality of life index really comes down, and which is why imaging becomes even more pertinent in these kind of patients. Okay, so where do we image? It's a very tricky thing to do, and it depends on your clinical colleague. Now, how much imaging he relies on, how much he doesn't want imaging for. And I feel chronic constipation is one of the key indicators these days compared to prolapse in this part of the world where I'm in. And I don't believe chronic constipation is true. Why is it chronic? The reason it's chronic is most of these patients go from door to door, get the standard therapy of laxatives and fibers. The underlying problem doesn't get diagnosed, and it becomes long-standing. And as a result of which, even the long-standing nature of constipation results in complications. And we have some examples of that as well. Obviously, pelvic floor pressure and pain, it's usually in the elderly, late middle-aged patients. They come with low back pain, pelvic floor pressure, excessive straining. So they feel the urge to go, but when they sit on the toilet seat, they have to really strain to even get a few pieces of stool out. So those are the kind of patients you really need to investigate. I take a history from my patient before they go in, and most of them, at least I would say 40% of them, say, I digitally evacuate. I have an incomplete evacuation. I have to digitally evacuate. And that itself is an indication for imaging, because something is not right, structurally or functionally. Pelvic dyssynergia, again, ties up with the young population. And difficulty in passing urine. So does it make a difference to diagnosis and management? Absolutely. I mean, the key difference is non-surgical, surgical. When do you avoid surgery? When do you need surgery? And that's where pelvic floor imaging makes a difference. Clinical evaluation is great. In the right hands, in the right experienced personnel, it's great. And I have great colleagues who have excellent clinical skill, but there are limitations to that, and it underestimates the problem, especially when you have a 3-compartment involvement, when you have the bladder, the uterus, and the rectum involved. It cannot evaluate an evacuation disorder. Now, some clinicians say, oh, I use ultrasound in my clinic. But again, ultrasound in pelvic floor is good for the bladder and for the uterus. Rectum, not so much, because you can't actually evaluate for intussusception, because you need active evacuation for that, and you can't do that in clinic. Peritoneal seal and enteroseal is in the cul-de-sac compartment, what I would like to call the 4th compartment, and this goes completely undetected in clinical exams. Okay, and the best part of my job and all our jobs who are in radiology is that we bring specialties together. And in pelvic floor imaging, you need a multidisciplinary approach. You need the urogynecologist, you need the colorectal surgeon, you need the gastroenterologist, and most importantly, you need the radiologist to bring this together and say, oh, guys, this is the problem. It's a 3-compartment. You need to approach it together. Otherwise, patient tends to go to different specialties, not getting the right answer or not getting a complete answer. Anorectal manometry is quite popular here. And they do go through anorectal manometry before coming for defecograms. And I go through the values of manometry before the exam. And I find that, again, very useful to actually predict what I'm going to see. Now, manometry has a lot of false positives, and asymptomatic individuals can have high rectal pressures as well. So it has its problems, and I think it's a great functional tool without the visual aspect. And when combined with imaging, it's a potent tool. So let's look at some anatomy quickly. Don't worry about it if you're not getting the orientation. This is just to get you started on reading some more anatomy. I've tried to put through images. I mean, when I started pelvic floor anatomy, it looked like something like that. It was very fuzzy. It was very difficult. But the more I read, I realized it's a very complex anatomy. But then again, what is complexity? It's a myth, right? I mean, once you understand it, everything becomes simple. So that's what I felt. Now, this image is a sagittal image. If there's one image that you need to remember through the whole presentation, this is the image, because this is the plane which we do dynamic imaging. So this is the anterior aspect, this is the posterior aspect, and you have the pubic bone, you have the bladder, you have the uterus, you have the rectum, and you have the cul-de-sac, you have the sacrum, and you have the anal sphincter. So this is pretty much how you will be looking at the dynamic imaging. And these are your three compartments, your bladder, the uterus, the rectum. Okay, so this is a very important image to keep in mind through the presentation. And if you remember this, the presentation will make a lot of sense. So now what I've done here is I've stripped off all the muscles, I've stripped off all the fascia, I've stripped off all the tissue, and I've just left the bare bones compartment contents. Now, if you look at this is the bladder. You have the uterus in the middle compartment, the vagina in the middle compartment, and then you have the rectum in the posterior compartment. Now, what we're going to do, so this is the ureters coming through, the vertical linear tubular structures. You have your fallopian tubes, your ovaries. So just to give you a perspective on how the muscles are added on and how that really is important for support. So you have your pubic bone, you have your coccyx and sacrum. And what you have here is the uterosacral ligament that keeps your uterus in position and in the anteverted position. Now, this is the ligament that usually gets snipped off during hysterectomy, and there is a consequence of that, which we will see later on. Then you have the pubovesical ligament holding up the bladder. So a lot of supporting structures holding up the three compartment contents. And then you have the pubococcygeus muscle. Now, this is actually a fan-shaped muscle. As you go down to the pelvic floor, most of these muscles are like slings, where they're actually like slings holding all the structures up, attached to bony attachments anteriorly and posteriorly. Okay, so these are the pubococcygeus, which is self-explanatory, attached to the pubic bone, attached to the coccyx. Okay, and this is actually a fan shape. So this is an axial view. This is what it looks like if you're looking at the lithotomy position. Okay, so this is your vaginal orifice, this is your rectum, and what you see here is a fan-shaped pubococcygeus holding up the middle and the posterior compartment. And on MRI, what does that look like? So the MRI, this is a T1 axial, and you see this concave linear structures. This is part of the pubococcygeus, which is in turn part of the levator ani. So that's your pubococcygeus, and this is what it looks like as you go around. And further on, you add the puboanalis muscle, again another part, deep fibers of the levator ani along the anal canal, holding up the orientation of the anal canal, and it's best seen on the coronal view. You see them highlighted here as low signal structures around the anal canal. Okay, then you have the pubovaginalis holding up the lower third of the vagina, and then you have the external sphincter. Now, sphincter anatomy is very important as well, and that leads to a lot of pelvic floor problems, and we'll come to that and during the examples. So you have the external sphincter muscle, internal sphincter right here. So that's very important as well. So just an overview again, and this is one of the key muscles I've just added right now, and that is the puborectalis. Now, puborectalis muscle is what maintains what we call the anorectal angle. And that's what is involved in a lot of functional disorders in pelvic dyssynergia. So very well to remember the orientation of that muscle and what it looks like on imaging, like a V-shaped concave structure around the anal canal at the level of the pubic symphysis. Okay, so what I'm adding further muscles are the iliococcygeus, which is higher up. You tend to see them in the coronal view right there, as well as the axial view, slightly higher than the pubic symphysis, again, part of the levator ani. Okay, there you go. You see this nice concave structure. This is the iliococcygeus muscle, a fan-shaped muscle. And then you add the coccygeus muscle, and then you add the fascia, the fat, and the skin. So that's pretty much your pelvic floor compartment with the muscles. Now, it can be very confusing with a lot of muscles, and I think a couple of readings is required to get the orientation right. But as long as you know which muscles are involved in the pathology, I think that should really be enough to kickstart a pelvic floor service. Okay, I'm going to skip the broad ligament because that's mainly involved in hysterectomy. So why is dynamic imaging useful? It gives you a good overview of the viscera, the muscle layers. It's multiplanar, so we do axial, sagittal, and coronal, and obviously the dynamic bit as well. But again, the people who have discouraged it initially said, oh, it's supine, patients are in a non-physiological position, they can't evacuate in the supine position. Now, initially, I felt that was a factor. I had patients who couldn't defecate and I put it down to supine position. But the more I did it, I realized that it can be done. And with the right trained radiographer, with the right instructions, the right training, I probably have a 97, 98% success with supine evacuation. And that's purely because of training. Nothing to do with me, nothing to do with the scan or anything of the sort. It's just position and training. And recently, some papers have come out saying that supine is as good as sitting upright, except in assessing rectal intussusception. Now, they say that rectal intussusception can be underestimated in supine, which to some extent is true. But if it is obvious rectal intussusception that needs surgical management, it will still be manifest. So what you're missing out is those, grade 1s, which actually does not need surgical management. So technically, it's not really affecting management. Motion is always an issue. So again, part of training, you have to be in the midline for dynamic images. And claustrophobia obviously is a problem in most MRI exams anyway. So something to get past with counseling. Okay, now this is one of the key parts of the presentation. Now, people are not used to doing it, just look through the steps. People are doing it right now. I'd love to hear back after the presentation to see how you do things differently. Now, I used to do colonic prep, put them nil by mouth, and before the DEFEACOGRAPHY. And I realized as I went along that it wasn't really required. And to be honest, I had better success without preparation than with preparation. And the reason why was the patient had feces in the rectum, right? And I injected jelly as well. And that gave a better sense of distension, and the patient was able to evacuate better with actually native feces inside rather than an empty rectum. Okay, so for me, actually, it worked in my favor. And I think I've seen a couple of other centers not doing any preparation right now, and it's really worked for them. We tend to get the patient to empty the bladder 1 hour prior. I give them a glass of water. I want the bladder full, but not very full. I want them moderately full because I want to see cister seals. I want to look for urethral dysmotility, but I don't want it so full that it's actually impeding rectal evacuation. Because when you have a full bladder, you're not going to push hard because you want to pee and you want to get off the table. That really defeats the whole scan. So you want to have an empty bladder initially, an hour before, and then fill it up just moderately. So then it doesn't interfere with the middle and posterior compartments. The most important person in the scan as part of the scan is the patient and your radiographer. Now I have 2 dedicated radiographers. Mainly I have a lead radiographer who's fantastic. I mean, she's as good as I am even looking at it right now because she's done that many. And I feel that you have trained, dedicated radiographers who do them, your success rate is going to be 100%. So I get them to take a history. For cultural reasons, I get a female radiographer to take history from a female patient. And I make sure that radiographer is the one who does the whole scan. I don't let them switch in between the scan because it actually upsets the patient in terms of instructions. So the patient has developed a relationship with the tech, and the evacuation is very sensitive process on the table. And you want to hear a voice that is you've already heard before, who you've spoken to, who you've been counseled by. So I make sure that the radiographer stays through the whole exam. I make sure there's a female radiographer for female patients and a male radiographer for male patients, because if you have a female patient with a male radiographer giving instructions, you're going to be very unlikely she's not going to evacuate because of the embarrassment. I get them to do the maneuvers in the changing room before they get on the scan. And that makes a big difference as well on what they do on the scan. I would give around 300 ml of rectal gel. So we put them in the lateral decubitus and we inject gel. We don't use a tube anymore. We slowly insert the tip of the bladder syringe. We don't use a Foley's tube. And it works very quickly. It goes in very quickly. And the sense of filling also is very good without the tube. So 300 ml for good distension. Now, patients with chronic constipation have decreased rectal sensitivity. So you actually need more gel to make them sensitive to the distension. So this is very important as well. It's one of the tips I've learned is that you need at least 300 ml of gel to make them sensitive to the fact, oh, I've got something there, I need to poo. Because these are patients who are chronically constipated. So their mucosa is not very sensitive to it. We put a diaper on once the jelly is injected. And we put a wedge, as you can see in this image, under the knees to keep it flexed, to simulate the defecation process. And it's most of the exams. I think probably 99% of the exams are monitored by the radiologist for the whole exam. I make it a point to monitor it. There have been instances sometimes when you're busy, but if you have a very experienced tech they can also do the exam independently. But I would always see the sequences before they get off the tape, before the post-evacuation phase. Okay, the protocols, we initially start off with static images. Then we do the thin slice, T2, fast spin echo, coronal, sagittal, and axial. We plan the axial and the coronal along the plane of the anal canal. And we find that it's just like the fistula protocol, where the plane is perpendicular to the anal canal for axial, and coronal is parallel. We do a sagittal midline T2 haste, Trufist in Siemens. It's Fiesta, I think, in GE. So at rest images, we do a 10-second image. Then we do a Kegel's maneuver. Kegel is basically pulling up your pelvic floor. How we explain it to the patient is that you are 1 kilometer away from home and you want to suddenly go to the toilet. What are you going to do? You're going to really hold up until you get home, right? So that's how we explain it, and it works very well. They really hold it up, and that's a pelvic floor contraction. Now, when you go to the evacuation phase, now for those of you who do the defecograms regularly, you might have realized that I've skipped the bearing down. Now, I used to do the bearing down initially when I started, but I've actually done away with it because I feel it really didn't give me any further information than evacuation. And I only do it in patients who I feel are not going to be cooperative, who don't understand instructions, so that the Valsalva gives them an idea that, oh, I'm going to bear down. This is what I need to do for evacuation. But other than that, I've done away with bearing down. I go straight to evacuation. And the recent consensus paper from the Society of Abdominal Radiology also recommends that you don't need to do the bearing down. So it's working well. We do 3 attempts of 60 seconds. One tip for the radiographers is that always start a sequence and then give the instructions. Because if you give instructions and you then start the sequence, you might miss the initial defecation. Some patients defecate quickly, especially patients with prolapse, sometimes do the initial defecation very quickly. So always start the sequence, visualize the image, then give the instruction. So then the evacuation then commences in front of your eyes. And I do it for 60 seconds. Patients tend to, intermittently defecate. I tell them, please hold down, because sometimes the abnormalities does not manifest if you're going to go intermittently defecate. So that is an instruction I give before as well. We do it for 60 seconds to give them enough time, around 3 attempts. And then once we get around 2/3 evacuated and we feel that they're not going to evacuate any further, then we go on to the post-evacuation, which means we take them out, send them to the toilet, sit them on the normal toilet, they evacuate whatever is left, and then we give them another diaper, and we bring them back, and we do the post-evacuation Valsalva. That's a very important sequence, and I'll tell you why it's important in an example later on. But it's a very important, it cannot be done away with. Some of the papers say it's optional, but in my practice, it's completely essential and gives me a lot of information. Okay, now this is from a paper by Dr. Rani Al-Sayed. She's a pelvic floor radiologist from Egypt. She's an authority in the topic, and quite a few papers of hers. And I love her approach, and something that I'm following here as well. And this is a great image in looking at the static part. Now, when we do dynamic defeco, sometimes I've seen that there are people who just forget the static bit and they go straight to the dynamic bit. Static is as important, and to look for the structures. And we've divided into 3 parts. We have the urethral support system, we have the vaginal support system, and the anal sphincter complex. So, just compartment-wise, the structures are divided. Okay. So this is a great approach, like a checklist, to look at the structures involved in holding up the pelvic floor on imaging. So if you look here, this is a urethral support structure. You have the urethra here, you have the vaginal canal with the edge shape or the butterfly shape, and then you have the anal sphincter, and you have the puborectalis around the anal canal. Okay, the dark, low signal linear structures here, this is the suburethral ligaments, and this is the periurethral ligaments. So these are ligaments holding up the urethra, maintaining the vesico-urethral angle. And this is the postpubic fat space. And this is very important as well. So the image on the right is actually a case where there's complex pelvic injury. The periurethral ligaments have been disrupted. The suburethral ligaments have actually flattened out and flaccid. And if you look here, the puborectalis muscle is completely torn off the pubic attachment. So this is a case where the urethral support structures have been disrupted, and the post-pubic fat space is increased. This is what we call the mustache sign, or the drooping mustache sign, which is indirectly saying, oh, your anterior compartment is sagging because of ligament injury. It's an indirect evidence of ligament and fascia injury. So, and this is just basically what I just mentioned. So here you have a square-shaped normal urinary bladder. Okay, this is again these structures holding up the anterior compartment. Here you have a square-shaped bladder because the fascia is all intact. But if you move to the image in the middle, you see the posterolateral corners of the urinary bladder and the vagina is sagging. And this is actually because of level 1 endopelvic fascia disruption. You have endopelvic fascia holding up these structures, and they have defects which have resulted because of injury, because of deliveries, and this is actually resulting in a weakening of the support structures of the bladder. This is called the saddlebag sign. Now, sometimes you have defects in the central portion of the urinary bladder. The lateral attachments are intact. This is a central defect with bulging of the posterior wall of the urinary bladder. Again, here you see that the puborectalis attachments have been disrupted. Okay, these are again the vaginal support structures. If you see here, there is vaginalis and rectalis combined in meshed fibers. But see here, this is a nice concave image. But here, it's irregular, it's slightly ballooned out and convex, and it's a sign of a mid-grade tear. Here, this is a high-grade tear. The puborectalis has completely been disrupted. There is no low signal structure representing the muscle. And coronal is another plane to look at, very thinned out. And here you have the normal structure. Okay, we don't see much of this. This is a post-hysterectomy case, and we call this a chevron sign. This is again from one of the articles by Dr. Al-Sayed. And here you see the vagina has virtually drooped. This is because of the level 3 endopelvic fascia disruption. And you see the chevron, traffic chevron, and we call it the chevron sign, basically saying the vagina has loss of support and its loss of level 1 fascia structures. Now, I used to wonder, why am I not seeing these injuries often? I look for them religiously, but I don't see them as often as in literature. And what we have to understand is that the normal deliveries, the forceps deliveries, the Vontos, the vacuum deliveries have decreased in frequency, and more difficult deliveries are now going to C-sections. So you don't see these sort of vaginal support structure injuries, bladder structure injuries, as much as you would have seen maybe 20 years ago. And that's probably the reason why we don't see them as much in our practice. And it's very unusual. Sphincter complex is very important. I look at the sphincter complex just the way you look at a fistula. Here, there is a defect from previous surgery. Why is this important? Okay, people say it's incontinence. Now, one more thing I would like to emphasize is this causes a lot of pain. And this then leads to very dysenergic pelvic movement because of the pain. So instead of relaxing your sphincter during defecation because of the pain, they tend to contract. And then they lose the coordination between abdominal muscles and the sphincter muscle. Then it results in pelvic dysenergia. So one of the other reasons why sphincter complexes abnormalities are important is to indirectly tell the physician, listen, this could be one of your underlying reasons for pelvic dysenergia. This is a complex injury. Your posterior internal sphincter is completely atrophied with fat replacement, and the external sphincter is also completely destroyed, replaced by fat. Okay, now people say measure the puborectalis muscle. I say, listen, okay, that's fine, but do you have? People say, oh, it's less than 1 millimeter. It's abnormal. I can't agree completely because I see a lot of variability. These are two nulliparous women, and look at their puborectalis muscles. They're completely different. This is concave. This is thick. And these are asymptomatic women, by the way. This was done for other reasons, and this is for like pelvic cyst or something along those lines. But when you look at this, you realize that there's a lot of variability. So I don't really lay a lot of emphasis on levator hiatus, transverse diameter, or on the puborectalis thickness, because I see a lot of variability, and I don't want a false sense of reassurance that, oh, this is going to be normal, when actually I see abnormalities during the functional imaging. So I don't lay too much emphasis on these measurements. Okay, another last example of a pubococcygeal injury. You have an intact one, you have it thinned out on the left. Asymmetry is a good sign. Asymmetry always should make you look for other pelvic facial and muscle injuries. And this is a chronic injury to the pubococcyges. You have the muscle on the left, which is normal, on the right, which is completely absent and atrophied. Okay, so I think enough of static. We have, I think, another 30 minutes, maybe less than that. And we'll go on to the functional, more interesting bit of it with more cine clips on. So MR defecography, again, I'm going back to the 3-compartment image. So this is the MR representation of that. You have your bladder in the anterior, the uterus in the middle, the rectum in the posterior, and then you have your sigmoid colon and your small bowel trying to peek through the cul-de-sac. So again, an image to keep in mind just before we start dynamic. Okay, so what are the measurements I do on the sagittal T2 images before I start the dynamic? I do the pubococcygeal line, which is a line from the inferior tip of the pubic symphysis to the last coccygeal joint. But please important, the last coccygeal joint is very important because I've seen people put it in the sacrococcygeal joint. And what happens is then you overestimate prolapse. So very important, you make sure you draw the line to the last coccygeal joint. So there you go. So you have the pubococcygeal line, you have the H line and the M line, which is a line perpendicular from the anorectal angle, posterior anorectal angle to the PCL, the pubococcygeal line. And that's an illustration of these lines. These are reference lines below which you look for descent of the bladder, the uterus, and the anorectal junction to assess for prolapse. Okay, so this is the measurements that you make to look for prolapse for each compartment. So for anterior compartment, you start measuring from the posterior inferior bladder base to the PCL line as they descend, and the antero-inferior cervix for the middle compartment for uterine prolapse, and for the posterior compartment, you look for the anterior anorectal junction to the PCL. So these are the gradings. Usually they say up to 1 centimeter below PCL is normal. So even though it says less than 3 centimeters, I think up to 1 centimeter is normal for all of us. So that's not prolapse, that's not descent. Anything above 1 centimeter, I would call it mild, moderate, and large based on the distance from the PCL. Now, enterocele is a tricky bit because I can have either small bowel or sigmoid colon, and they're usually in the rectovaginal space. And if it's below the upper third of the vagina, then it's a significant enterocele. Okay, so you've got the basic measurements of lines. One of the most other important measurement is the anorectal angle. Okay, and I've seen people get this wrong. What we do is we need to make sure where the levator plate is, and then we look at the anal canal. And that's what needs to be measured. Now here, for example, you've drawn through the anal canal, but this is actually through the rectal canal. And this is actually exaggerating the anorectal angle, which means your narrowing is going to be underestimated. Now here, you have the correct method, which is the anal canal and parallel to the levator plate, which is the plate attached to the anorectal angle from the tip of the coccygeus. So that is what I use, or even parallel to the PCL is good enough. And I've seen that also very useful. Now, why is this angle important? So in a normal defecation process, this angle increases. So from 85, it goes to 120, 110. But in paradoxical puborectalis contraction, in pelvic dysenergia, what happens is this angle gets very narrow. And that's why this angle measurement is very important. And how you measure it as well. So just a quick reminder of the phases of dynamic before we start the cines. Okay, so what you have here on the left is the rest. You don't ask the patient to do anything. You're just relaxing. You're doing a true FISP here. You're just asking them to relax. This is a baseline to compare the Kegel and the evacuation with. Okay, and then you ask them to do the Kegel, the contraction, the clenching, or the squeezing, whatever you want to call it, or whatever your patient understands. And you can see there, the Kegel is to assess active pelvic floor contraction plus the anorectal angle. Look at how narrow it's become during the Kegel maneuver. So there's a narrowing of the angle that you measured on the previous slide. And then you have the evacuation that happens you see feces coming out. There you go. You see a descent. This is an abnormal case, by the way, but I just like the way it was shown. So this is a good example. So you have the evacuation phase. Again, I don't do the bearing down unless I feel there is a need for it. Okay, so let's look at some cases. Just look at the right image. So let's remind you that this is anterior, middle, posterior. This is a haste, by the way. You see the jelly being evacuated by the patient. You see the descent. Okay, let's play that again. So this is just to compare with, to see what it's at rest and what happens during defecation. And I'm going to stop there. So now you see that the anterior compartment is fine. It's not coming below the PCL. The uterus is above the PCL. So there's no anterior and posterior compartment. However, if you look at the anorectal junction and the anal orifice in the anorectal junction, it's actually way below the PCL. This is the posterior compartment involvement, solitary posterior compartment involvement. This is actually rectal descent. And sometimes these present with incomplete evacuation in the later stages. Okay, there's another example. Again, please pay attention to the posterior compartment. You see jelly being expulsed. Okay, let's do that one more time. Okay, I'm going to stop there. Just wanted the previous image. But if you see here, there is an anterior bulge of the rectal wall. This is what we call the rectocele. And then there is progressive rectal intussusception. We have better examples. This is just one case where there are both of them. Now, the rectocele, why is it important? Patients with rectocele always complain of incomplete evacuation because there's retention of contrast in that pouch. And even air entrapped in the pouch is considered as retention, not only feces, because they feel it. So air and the jelly is considered as retained contents, not just the jelly. So if you see patients who have evacuated the jelly and see air in the pouch, it's still retention in the rectocele. So this is an anterior rectocele. Okay, let's just play the video here. Another example of a see the anterior bulging. So what is happening here is, if you see the axis of the defecation, because of the weakness, the axis of the direction of the defecation is towards the anterior wall, not to the orifice. So what's happening actually is the jelly is actually filling up the rectocele, causing the anterior rectocele to manifest. And then you have whatever is left to go through the canal, which is why they have to really strain multiple times to evacuate and still feel incomplete because of the retention in the anterior rectocele. Here, there's an incidental fibroid, tend to give the feeling of bearing down as well. In this patient, there is actually a cystocele as well, and there is a mild uterine prolapse as well. Okay, let's look at this example. I mean, if there was an audience, I would be asking questions, to be honest, but at this point, we can't do that. Again, another example. Okay, let's do that one more time. And here, the descent of the uterus and the vagina is quite marked compared to the previous example. And here, it's a three-compartment involvement. You have the urinary bladder descending. You have the lips of the cervix descending, which is your landmark measure from the PCL, and the uterus descending. And you have the anterior rectocele as well, with the anorectal descent. This is a three-compartment involvement. Now, just look at the anterior compartment here. And look at the cystocele. Look at that funneling that's happening. Now, these patients tend to come with stress incontinence whenever they cough, whenever they sneeze, especially patients with cystocele and urethral hypermotility, where the angle between the urethra and the bladder becomes acute. They come presenting with stress incontinence, in addition to the pelvic floor descent. So even when I take a history and I hear incontinence, I can predict that this patient is coming with cystocele. Okay. So the rectum is emptied, there is anorectal descent. The bladder has stayed where it was, so there's no anterior involvement. But look at all of this stuff here. This is peritoneal fat containing small bowel and sigmoid colon. This is actually an enterocele and a sigmoidocele through a weakened pelvic floor. This is a post-hysterectomy patient. Okay, anterior rectocele bulge, you normally measure it from the line passing through the anal canal and see how far the anterior wall of the rectum is. And that is the degree of rectocele. Usually it's more than 3 centimeters is moderate, more than 6 is marked. So see here, look at the air that's filling it. This is retained, this is retention. This is not emptying, this is retention. Now, what I've done here is this example is a great, it's a good example to show why post-evacuation is important. Now you see that there is enterocele and sigmoidocele, but it's below the PCL, but it's in the mild category. Now, what I've done is I've sent the patient back to the toilet after the evacuation. She couldn't evacuate more, brought the patient back, and then did a Valsalva and see what happens after that. The sigmoidocele and enterocele then manifests after the rectum is emptied. And she distally evacuated the rectocele as well, by the way. So the thing is, post-Valsalva is extremely important. Otherwise, you will underestimate, particularly 2 things. One thing is the cul-de-sac descent and the rectal intussusception. I find that rectal intussusception gets manifest when the rectum is empty rather than full. And it's usually best seen in the post-evacuation phase. So it's a large enterocele. Okay, now, so we just talked about intussusception. So let's look at this, this dynamic imaging of evacuation. So you see the descent of the bladder, the uterus. It's a 3-compartment involved, but look at the mucosa here. Rectal mucosa is invaginating into the distal rectum, anal canal, even up to the anal orifice. This is rectal intussusception. Now, there are gradings for this. And why is grading important? It's useful for the surgeon to know when to intervene surgically. Now, there is something called the Oxford intussusception scale. Usually grade 1 is just a buckling. Now, some of us will pass it off as normal because our idea of intussusception is telescoping of mucosa. You don't have telescoping, you just see buckling. Now, if done supine, if you see buckling, they're definitely going to have intussusception if they're going to be upright or sitting on the toilet. So grade 1 is actually intussusception. Now, even if you pass it off as normal, it's fine because they don't do anything about such low grade intussusception. So in terms of management, it doesn't make a difference. Then you have the grade 2, where you have the rectal mucosa invaginating into the rectal canal, then into the anal canal, and then through the orifice. Now, the recent consensus is that all you have to say is into the rectum, into the anal canal, and outside. There's 3 grades. And that's the consensus statement from the SAR. So if you find that's easier and your physician or your surgeon is fine with that, that works well too. So there you see another case of intussusception. And this is actually a grade 4 intussusception, is up to the anal canal, up to the level of the orifice, not quite protruding out of the anal orifice. So this is a grade 4 rectal intussusception. And this is what we call the arrowhead sign, or the arrowhead intussusception, because you have a posterior rectocele and an anterior rectocele. Okay, and just before we go for the cases, another very marked case. It looks here, it looks absolutely hunky-dory here, but look at the amount of descent that happens during defecation. It's just hanging out virtually. It's not procedentia yet, but it's just hanging out completely and just crowding out the pelvic hiatus. Okay, so let's look at this particular case. Now, just before I play that, the act of defecation, though simple to us, is it's a coordination. It's like an orchestra. When you want to defecate, your abdominal muscles contract, your intra-abdominal pressure increases, and then your pelvic floor muscles and your sphincter knows it has to relax, and then your anorectal angle widens, and you evacuate. And we take all of this for granted. But there are patients who have a disruption of this coordination. The abdominal muscles contract, but the pelvic floor does not. And then they have the sense of obstructive defecation. What is the cause for it? I think poor habits, poor defecation habits, poor diet, even sexual assault, injuries, abuse, have all been put as causes for this. Anal fissures, all these can produce paradoxical contractions. So look at this. I expect the angle to widen and broaden and increase, the anorectal angle. But on the contrary, it's actually decreasing. The angle is decreasing. It's indenting into the to the anorectal lumen. And what's happening is the feces has to go around it. It's like your hairpin bends around hill stations. You know, the feces has to take a sharp turn, and the sensation of obstruction is immense. And when the patient gets out, you ask them, "How did you feel?" And he says, "Okay, that's obstructive defecation." So this is what the patient is going through, and this is very difficult to assess sometimes clinically. So this is the indentation. And at rest, sometimes you can predict puborectalis paradoxical contraction by just the thickness of the puborectalis. I don't have a fixed measurement. I just eyeball it. But when I see an indentation like that, I know that we're dealing with pelvic dyssynergia. So this is a case of paradoxical puborectalis contraction. Okay. The other thing never to forget after dynamic is to look for incidental findings. I've seen colonic tumors, ovarian cysts, mural cavernoma of the sigmoid colon, which was missed actually, and the patient had a CT scan for this pain because the pelvic floor imaging was normal. And then you see this because you couldn't pick it up on MR. I mean, hindsight is everything is easy, but you couldn't pick it up on the MR. But incidental findings, kindly look for it. Now, going through just 3 or 4 cases before we wind up here is, this is a 55-year-old post-hysterectomy patient. Now, I chose this particular patient because post-hysterectomy, people put it down to age as pelvic floor weakening, but post-hysterectomy results in the suspensory ligament disruption. but also it leads to disruption of the autonomic nerve supply of the pelvic floor and the suspensory ligaments, which actually predisposes post-hysterectomy patients to weakened pelvic floor. So even if they're a young patient, if they've had a hysterectomy, the pelvic floor is going to be weak. They can have symptoms of obstructive defecation. So if you look here, you see a 3-compartment involvement. The vaginal vault is also descending below the PCL. There is a mild paradoxical contraction, but then widens out. But you see the rectocele that's manifesting here. And as she strains and she consistently strains, once the rectal jelly gets evacuated to, let's say, 50% or 60%, then you see the rectal intussusception. It's manifesting, it's coming in. See, there you go. So you don't see this initially. You only see it during the later phases of defecation. So it's very important to wait for at least 3 or 4 attempts for good emptying and even the post-evacuation phase. And this is the sort of grade 2 rectal intussusception. That's a cystocele, a bit of urethral dysmotility leading to incontinence, and that's a bit of the sigmoidocele as well. Okay. This is the patient with obstructive defecation. Again, another case, 45-year-old. Now you see a posterior compartment involvement, but you also see a middle and anterior compartment. Now I'm going to stop there and I'll tell you why. Look what's happening here. Everything is getting crowded between the pelvic hiatus. Look at the way it's squishing the rectal canal. So the initial defecation phase is easy for the patient. By the time she goes to the later phases, she's not able to empty whatever's there because it's completely crowded and it's causing effacement. So there's no way that can come out, and that leads to incomplete defecation. And also this patient has a rectocele as well. Okay, solitary rectal ulcer is something we see on and off. It's a debatable topic. Solitary in itself is a misnomer because it's not solitary. It's a multiple little ulcerations with fibroblasts lining the lamina propria with mural thickening. And you see here, you see these thickened mural areas in the mid-rectum. These are areas of ulceration that is picked up on colonoscopy and diagnosed with histopathology, and it's a benign condition. But even though it's a benign condition, it really causes a lot of problems. So if you see the dynamic images here, look at what's happening here. Look at the thickened area intussuscepting into the rectal lumen. This is again the arrowhead sign. Now, what they said was solitary rectal ulcer leads to intussusception. Actually, the current thinking is now actually reversed. What they say is chronic constipation results in intussusception, and the apex of the intussusception undergoes pressure necrosis, resulting in this ulceration and fibroblast proliferation, which is a vicious cycle. It becomes narrow, more intussusception until it results in anorectal prolapse. This is our last final case. And I'm sure everyone is quite familiar with what the anorectal angle is supposed to do. And if you see here again, the angle is failed to relax, and then it results in paradoxical contraction. Again, this is an obstructive defecation because of paradoxical puborectalis contraction. So what do we have for dyssynergia? Now, thankfully, we have a good physio team here who does biofeedback with excellent results, especially in the younger patients with dyssynergia. And most of these patients have been treated with laxatives, with fiber diet, and they've just been mixed response. But once they get into biofeedback and retrain to coordinate their muscles, they just improve dramatically and their life changes. In patients with who don't respond to biofeedback, we have botulinum toxin injections, diet changes, obviously, pelvic floor exercises, which I feel anyone over 35 should be doing while they're sitting. We sit around, as radiologists, we sit around a lot. Our pelvic floor is never engaged. I think we need to actively do pelvic floor exercises at some point during the day, just to keep it intact. Pain management is useful, especially in cases of fissures. Low-dose muscle relaxants, not commonly used, and obviously surgery if there are any structural issues. So in summary, pelvic floor dysfunction is not going to go away. It's actually a growing problem. And as radiologists, flow disorders can be split into organ prolapse and dyssynergia. And imaging mainly helps in deciding somebody needs non-surgical or surgical management. But the scan is so easy, but it's made easy because the patient training is important. Patient training is done properly by the experienced tech. The scan is very easy to do, very low cost in terms of equipment required. And in terms of reporting, I think I follow the rule of 4s. I've seen rule of 3s in some presentations or papers. And I usually start by looking at ligaments, fascia, muscle, and sphincter. This is a rule of thumb. Then I start going through the PCL, the H line, the M line, the anorectal angle, and then the 4 stages, the rest, Kegel, evacuation, and the post-evacuation. And then the 4 compartments I assess after the dynamic. So if there are people who want to get started, these are the few papers I would recommend reading. This is from the Radiology Clinics. It's an excellent detailed paper, tells you how to go about it, what to look for. It's added detail in addition to what I've said today. And this is the consensus paper if you want the right definition and the right templates and the right terminologies. So I think with age, we realize that we get wiser, but we also learn new skills. You can laugh and cough and sneeze and pee all at the same time. And I think it just ties up quite well with the pelvic floor abnormalities we talked about. And that's it from me. Thank you for your time and thank you for listening. Thank you.
Thank you, Dr. Jagdish. It's an excellent talk and very useful. And of course, most of the residents, we feel that they feel that it's a difficult topic, but you really made it simple and you explained the technique very well, including the anatomy and dynamic images. Thank you for really presenting this talk. I have one question. What is your experience post-surgical? After that, we'll go to some questions which are in the chat box.
Sure. So with patients with rectopexy, we have had a few patients who had rectopexy because, and they were not imaged before. They were clinically diagnosed and they had rectopexies and they've had pelvic floor failures. We haven't had that many, but they always come back with anterior and posterior middle compartment not being addressed. The second technical problem is artifacts. So some patients have these metallic rectopexy attachments. And when we do the dynamic, the static images are fine. But the challenge is the dynamic images because there's a lot of artifact in Trophis or Fiesta. So then what I did, we had one last week and we switched to T2 Haste dynamic and that really helped. So in terms of technical aspects, this is what I would do. In terms of results, it's very mixed. I would say it all depends. And most of our patients who are post-surgical are from outside facilities. We haven't had any post-operative follow-up because obviously it's not indicated unless it's a study. There was a paper recently, I think from Iran, I think, was actually not a post-surgical treatment, was post-biofeedback. And they had funding to do post-biofeedback MRI dynamic. And there was a huge difference in the parameters that was measured before and after. So, but coming back to your question, post-surgical, it's a mixed appearance, but technically it can be worked around. We see mixed results, but when we see them coming, we realize that they did not have imaging before and this multiple compartment involved that result in pelvic floor failure.
Thank you. There are some questions in the chat box. One is from Dr. Gayatri. I will just read out, probably you can also go through. Does widening of the hiatus between the rest and bearing down have any significance? If there is no significant descent in any of the compartments?
Okay.
Shall I read again?
No, that's fine. I got that. So pelvic hiatus can be measured in 2 ways. Now, you can use the H line, which is the line between the, I tend to use the H line as the hiatus line because that's the inferior tip of the pubic symphysis to the anorectal angle. Okay, so that is on the sagittal plane. Now, there are some articles that say you can do a lateral measurement at the level of the pubic symphysis and from levator to levator at the maximum transverse diameter. But what, as I said before during the presentation, these are just markers. You can't specifically say that this is abnormal. I've seen normal patients with pelvic hiatus of 5.3 who are asymptomatic. I've seen symptomatic patients with hiatus of 4.7. And these patients actually are the ones with obstructive defecation because they have a weak floor. The anterior and posterior compartment descend, and then they obstruct the rectum, as I showed in that example. So actually, a smaller hiatus is actually more problematic sometimes. And you don't have enough space for all the 3 compartments to descend. So hiatus measurement should be done. And it can be an indicator, but it cannot be diagnostic. It cannot be specific to any sort of weakness. You have to treat it with caution.
There is one more question in the chat. Probably you already explained this. What are the most common sequences we need to do for defecography? Mr. Syed, radiographer.
I can bring up that slide. I think if that's easier. So it's actually very straightforward. It's three plain non-dynamic sequences, three static sequences, high resolution. You just have to be careful to angle the coronal and axial along the plane of the anal canal as you do for fistulas, so that you get the sphincter end on. Okay, so there you go. So, and the dynamic is very important. The dynamic instructions, when you give instructions, and we usually use TrueFist. We use TrueFist. You can use Fiesta. You can use Haste as well. I find TrueFist very good because I get these nice demarcations between compartments. So these are the sequences that we use. It's very straightforward. It can be easily set. The radiographers really can do it independently once they've done it quite a bit, and it's straightforward. The key is not the sequence. The key is to get the patient evacuated in the supine position. The sequences are just straightforward. So evacuation is key, and that depends on the patient and your radiographer, not on you. But you have to train them very well.
Thank you. Actually, there are many comments about great presentation, excellent presentation, brilliant presentation in the chat box. We really appreciate for the presentation. Any comments, Dr. Kavita, Dr. Vijay Bhaskar, or anyone?
Thank you, Dr. Jagdish, for honoring our request and being with us. Really, it's really very nice to see your slides and then videos, and it's a world-class presentation. Thank you very much for accepting our invitation and being with us on the request. We wish to have some more presentations in future too on this platform.
Yeah, my pleasure. Thank you for having me.
Thank you very much.
Thank you. Then we conclude the session. Thank you.
Dr. Reddy. Thank you.
Yeah.